Chapter 9: Oral Manifestations of Systemic Diseases. Condition: hyperpituitism. Cause: excess growth hormone produced by the pituitary gland, most commonly caused by the pituitary adenoma. In children, it causes gigantism. In adults, most commonly in the fourth decade, it causes acromegaly. The location is generalized bone involvement, affects only certain bone. Clinical features include excessive growth of the skeleton overall, enlargement of the hands and the feet, increase in rib size, enlargement of the mandible, the maxilla, the maxillary sinus, separation of teeth with malocclusion, frontal bossing, and enlargement of the nasal bone. The treatment may involve pituitary gland surgery, and the diagnosis is laboratory. Hyperthyroidism, also known as Graves' disease. The cause is excessive production of the thyroid hormone. It's found in children and adults. It's a systemic disease, and its clinical features include rosy complexion, erythema of the palms, excessive sweating, fine hair and softened nails, exophthalmos, anxiety, weakness, restlessness, cardiac problems. Children, premature exfoliation of deciduous teeth and premature eruption of permanent teeth. In adults, osteoporosis, dental caries, and periodontal disease appears to progress rapidly. The treatment includes suppression of the thyroid activity, and it may involve surgery, medication, and radioactive iodine. The diagnostic process is laboratory. Hypothyroidism. Cause: decreased production of the thyroid hormone. It happens in children, and it's called cretinism, and the location is systemic. In children, it appears as a thickening of the lips, enlarged tongue, delayed eruption of the teeth. In adults, it just includes an enlarged tongue. Radiographically, delayed eruption patterns may be observed. Hyperparathyroidism. Cause is excessive secretion of parathyroid hormone. Primary may be caused by the hyperplasia or tumor of the parathyroid gland, and secondary may be caused by renal disease and vitamin D deficiency. It usually happens in adults. Its location is systemic, and clinically, joint pain or stiffness, lethargy, and loosening of the teeth. Radiographically, well-circumscribed bone lesions, changes in the trabeculation, partial loss of the lamina dura. Microscopically, bone lesions indistinguishable from central giant cell lesions. Treatment is dependent on the cause, and the diagnosis is laboratory. Diabetes mellitus, caused by the abnormal high blood glucose levels resulting in a lack of hormone insulin. It happens in type 1 and type 2. Type 1 peaks age onset is 20 years, and type 2 is 40 years and older. The location is systemic. Clinical features include accelerated atherosclerosis resulting in impaired circulation of blood, increased risk of ulceration, gangrene of the feet, high blood pressure, kidney failure, stroke, eye damage and blindness. Neurological complaints, decreased resistance to infection, includes oral candiditis, slow wound healing, bilateral salivary gland enlargement, xerostoma, usually with uncontrolled diabetes, and accented response to dental plaque. Radiographically, increased severity of periodontal bone loss. Treatment may include controlling the blood glucose with insulin injections, oral hypoglycemic agents, and diet. The diagnosis is laboratory. Addison's disease, caused by the insufficient production of adrenal steroids caused by malignant tumors of the adrenal gland, infection such as tuberculosis, often undetermined, possibly an autoimmune disease. The location is systemic. The clinical features include a brown pigmentation of the skin, or bronzing if you will, and oral melanotic macules. The treatment is steroid replacement therapy, and the diagnosis is laboratory. Iron deficiency anemia, caused by nutritional deficiency of iron intake, blood loss, increased demand for iron, or poor absorption of iron. It can happen at any race, age, or sex. The location is systemic. Clinically, weakness, fatigue, low energy, shortness of breath. Orally, angular colitis, papillary atrophy of the tongue with burning sensation, pallor of oral mucosa. Microscopically, microcytic hyperchromic red blood cells. The treatment is treatment of the underlying cause, increasing iron intake, and it is diagnosed in the laboratory. Palmer-Vinson syndrome. Cause is chronic iron deficiency. Usually it occurs in adults. It's a systemic disease. Some features as iron deficiency with increased risk of esophageal or oral cancers. Microscopically, mycetic hypochromic red blood cells. The treatment is the treatment of the underlying cause and increasing iron intake and is diagnosed in the laboratory. Pernicious anemia, caused by deficiency of intrinsic factor produced by partial cells in the stomach. Autoimmune mechanics or mechanisms most likely usually occurring in adults. The location is systemic. Clinically, the features are weakness, fatigue, skin pallor, nausea, dizziness, diarrhea, abdominal pain, loss of appetite, weight loss. In the oral cavity, angular colitis, pallor, painful erythemus, and depapulated tongue. Mucosal ulcerations, microscopically abnormally large blood cells. The treatment is vitamin B12 by injection and is diagnosed in the laboratory. Folic acid and vitamin B12 deficiencies causes malnutrition, increased metabolic requirements, usually occurring in adults, is a systemic disease. It includes the features are weakness, fatigue, skin pallor, nausea, dizziness, diarrhea, abdominal pain, loss of appetite, weight loss. Orally, angular colitis, pallor, painful erythemus, and depapulated tongue. Oral ulcers. Microscopically, abnormally large red blood cells. The treatment is dietary supplements if nutritional, and the diagnosis is in the laboratory. Thalassemia, caused by an inherited disorder, autosomal pattern minor, disorder of hemoglobin synthesis. The age usually beginning in early childhood. The location is a systemic disease, and the clinically can be seen as yellowish skin, pallor, fever, malaise, weakness, enlarged liver and the spleen. In the face, prominent cheekbones, depression of the bridge and the nose, prominent premaxilla protrusion or flaring of the maxillary anterior teeth. Radiographically, atypical trabecular patterns, a salt and pepper effect, thinning of the lamina dura, circular radiolucencies in the alveolar bone also described. The treatment is still experimental and it can be diagnosed clinically and in the laboratory. Sickle cell anemia. This is an inherited disorder and it's an abnormal hemoglobin in red blood cells. It usually occurs before the age of 30, mostly in African American individuals and those of Mediterranean origin, usually occurring more in women than in men. It's a systemic disease. Clinically, the features are weakness, shortness of breath, fatigue, joint pain, and nausea. Radiographically, loss of trabeculation with large irregular marrow spaces. Microscopically, sickle-shaped red blood cells on a blood smear. The treatment is symptomatic and supportive. Oxygen, invasive, and oral fluids, intravenous and oral fluids. The diagnosis is laboratory. Aplastic anemia, described in all circulating blood cell types because of severe depression of bone marrow activity. Primary cause is still unknown. The secondary is drug or chemical agents. It's primarily found in young adults. The secondary form occurs in any age. The location is a systemic disease. Clinical features include infection, spontaneous bleeding, and peripitic spots. The treatment is experimental, poor prognosis. For the secondary form, removal of the cause. Diagnosis is laboratory. Agranulocytosis. Marked reduction in circulating neutrophils. Primary form may be immunologic. The secondary is drug or other chemicals. The secondary form occurs more in females than in males, and it is a systemic disease. Clinical features include a sudden onset of fever, chills, jaundice, weakness, and sore throat. Oral infections with rapid periodontal destruction and gingival bleeding. Treatment includes transfusion, antibiotics to control the infection, and removal of the causative agent if identified, and it can be diagnosed in the laboratory. Cyclic neutropenia. The cause is autosomal dominant gene ELA2 19p13.3. It happens from birth and it occurs in male and female equally. The location is the oral mucosa and the periodontium. Clinical features include gingivitis, periodontitis, ulcers, and hemorrhage. Radiographically, alveolar bone loss and pocket formation. Microscopically, cyclic diminishment of neutrophils in peripheral blood. The treatment is root planing, scaling, and antibiotics, GCSF. Diagnosis is clinical and blood studies. Celiac disease. Cause: sensitivity to dietary gluten results in injury to the intestinal mucosa and subsequent anemia. It happens, it's a systemic disease. Clinical features include same clinical features as for anemias, diarrhea, nervousness, and paresthesia of the extremities. The treatment is adherence to gluten-free diet, and there is no diagnosis. Thrombocytopenic purpura. It's caused by the severe reduction of circulating platelets. Idiopathic cause is unknown, and the autoimmune is caused by drugs, often chemotherapeutic agents. The primary and autoimmune types, usually in children and young adults. No age prediction for the secondary type. It's a systemic disease. Clinically, spontaneous hemorrhage, lesions of the skin and or the mucosa, gingival bleeding, frequent nosebleeds, and blood in the urine. The treatment includes transfusion, systemic corticosteroids, a splenectomy, a discontinuation of the causative agent, and it can be diagnosed clinically. Hemophilia, type A and type B. It's inherited through an X-linked factor. Type A is factor 7 deficiency, and type B is factor 9 deficiency. Identified in childhood and affects boys. Its location is systemic. Clinical features include spontaneous bleeding and the risk of hemorrhage after oral surgery and dental hygiene processes. The treatment is replacement of missing clotting factors, and it can be diagnosed in the laboratory. Bisphosphonate-associated osteonecrosis. The cause is bisphosphonate therapy for osteoporosis, multiple myeloma, metastatic carcinoma of the breast and prostate, and Paget disease. The location is the maxilla and the mandible, and the clinical features include exposed bone persisting more than 8 weeks in the patient taking biphosphonate medications. It can be diagnosed clinically and microscopically to rule out metastatic disease.